For about 7 years now, have run a number of units in our public health sector in Western Australia, and in the last 5 years have been running a private TMS company that has, we now have 10 locations, 12 different TMS machines. So a couple of the sites have more than one TMS machine. We work with pain physicians, neurologists, neurosurgeons, and psychiatrists to treat patients with TMS. In amongst that kind of giant number of patients, I've now kind of sort of just crossed the 500 mark for patients treated using Neuronavigation. So that's using MRI-guided TMS, which is what we'll talk about mostly today. So I know there was a bit of a talk on TMS earlier in the week, and I think most people are actually neurologists in the room, but who hasn't heard about TMS? Who knows nothing about TMS? Okay, that's good, because we can skip over a lot of the basic stuff. There are kangaroos in Australia. There's actually heaps of kangaroos in the suburb I'm in Perth, but no, we don't ride kangaroos to Perth. I'm going to skip over a lot of this because I think I'll go briefly just some of the stuff in psychiatry, because that might be interesting to you as neurologists, but then I'll try and focus more on the neuronavigation towards the end. So we will skip through the history, because I'm sure you covered that when you did TMS earlier. One of the things that I find patients often struggle with when they think about TMS is the fact that it is neurostimulation, and so it has its origin in other forms of neurostimulation. But the thing we like about TMS is its safety, in terms of not really having much in the way of side effects at all. So it was a bunch of neurologists and psychiatrists together that first used TMS to treat depression in the late 80s. It didn't take very long for them to publish in the Lancet around treatment for depression. And fast forward about 10 years, a famous Australian published the first sort of internationally recognised RCT on the benefit of TMS over sham TMS for the treatment of depression. This was looking just at TMS in depression in terms of, we're seeing this sort of rapid acceleration of the research into TMS. And if I could substitute this word in with stroke or with tinnitus or with any other neurological condition, we'll see an equally kind of large uptick in the last couple of years. I think most interestingly at the moment, we're seeing TMS research a lot in the field of dementia, so Alzheimer's. There's a couple of research projects in Australia, one that I'm loosely involved in around using TMS in Alzheimer's, Parkinson's, and autism spectrum disorder as well. And so we'll talk a little bit about MRI-guided TMS today as part of, I guess, the future of TMS. The way we deliver TMS in terms of not using a single pulse, single cone coil, or a double cone coil, or do we have a flayed double cone coil, or do we have a deep TMS coil? Are we doing 1 hertz, 10 hertz, 20 hertz, theta burst? As we understand and explore TMS more, we're finding there are a lot of different ways of actually delivering TMS. So it's not just now TMS is TMS, but we have this, I guess, this scope of expanding practice in terms of what we're trying to treat and how we might treat it. So the short answer, I will skip over the science because I know you would have covered this in depth, and you probably all know it better than I do anyway. One of the things that people talk a lot about as psychiatrists is they talk about whether or not TMS is high frequency being stimulating and low frequency being something that will slow people down, help with things like anxiety. But we don't like that way of thinking about it because it doesn't work with the biological science. So if we actually look at cells, when we're treating with any form of TMS, we're causing long-term potentiation, particularly with the higher frequency ones. We're enabling cells, in fact with all Hertz TMS, we're enabling cells to get better at talking to each other. And the more we do TMS, the better that sticks. So we're creating an environment in which the cells are more able to communicate with each other. The long-term depression actually comes from activating that separate circuit, that brake circuit, if you like. So it's an inhibitory circuit, but it is actually still being stimulated. So it doesn't matter if we do 1 Hertz or 10 Hertz, it's all stimulatory. The shape of the coil makes a big difference in terms of the actual way we affect the magnetic field. So if we look back at this slide, this is not a real person's head, but we can sort of see that there is a hot spot underneath the middle of a double cone coil that delivers the most amount of eddy current, which is what causes the cells to depolarize. But if we change the shape of the coil, like over here, these all correspond to these very perfectly round brains on the right, where we can see that there is a big difference. If we take companies been making these H coils, like these sort of 13 and 14 here, and you can sort of see you get quite a big band of activation and quite a deep activation versus often we're doing peripheral TMS in neurology, in assessment of impact of stroke. We'd be using the single cones, like at the top here, and you can see they have a much sort of well, it's not quite as fine, but they have a very sort of a predictable response. We get to the ones that we use for treatment more, which are this row here of double cone coils. We see we start to get very precise in terms of what we're targeting, and that's because the overlap of the magnetic field essentially creates like a hot spot in the middle of those two, where it's creating the most current, the most eddy current, and therefore, if the overall field can be lower, the surrounding tissue is inactivated only in the hotspot. So we don't use all of these in practice at all, actually, not very many of them, but it does start to give us that idea of what we could do with TMS. So it starts to raise that question of, if we knew there was something we wanted to treat in some particular way, we could adapt the technology, we could adapt the coil to that. The big issue we have in psychiatry and to the same extent in neurology is that there's a limitation to our understanding of just how every cell interacts with every cell in an individual. So some of this is big science that's still quite a decade or so away, I think, before we are able to have sort of true precision TMS. Nothing too particular, other than just to say that if we want to go deeper, we lose focality, and if we want to go focal, we lose depth. We can't have one. We can't have both. The trade-off in the way magnetic fields are generated mean that we get one or the other. I went through this. We replicated this study a couple of years ago, looking at what is the difference between 10 Hertz TMS and 1 Hertz TMS, and found that actually you get pretty much the same activation with the 1 Hertz as you do the 10 Hertz, except the 1 Hertz seems to cause that balancing effect where it's almost stimulating the cells that are then going to be the brake, and so that's why we talk about that kind of the idea of it being inhibitory. In depression, we think a lot about TMS as being something that we want to hit a deep structure though. So you'll hear me say a lot, or if you've done any sort of research in psychiatry, that we talk about the left or right dorsolateral prefrontal cortex. But actually what we're interested in is the connections through the anterior cingulate cortex into the limbic system. And this is the limbic system that we want to be stimulated. This is where we see the change come about when we treat depression with TMS. And again, this is something that we did in our lab in Western Australia, where we actually took rat craniums and we did not transcranial magnetic stimulation, but no cranial magnetic stimulation, and actually saw change in the firing of cells in the limbic system from stimulating the dorsolateral prefrontal cortex. We eventually didn't use this coil. We made a tiny, it's like a smaller than a pencil single coil TMS coil, so that we weren't stimulating the whole rat brain, but just the dorsolateral prefrontal cortex, because otherwise this magnetic field would be far too big. All right. So let's get to something. and again, when we sort of think about depression, we've got these sort of functional MRI studies that show that we do take somebody who has depression versus a functional MRI without, that we actually see these changes in the, this is the SGC, but you actually see the changes in the subgenual cingulate hyperactivity after a course of TMS starting to more mimic what we found in normal, healthy individuals. We've done a fair, more recently, perhaps in the last sort of 2 years, we've been working more with our neurology colleagues in a couple of studies, and we've got a couple underway at the moment. We've recently finished a trial doing TMS for post-stroke aphasia. I haven't included any of the slides here because it's yet to be written, but we had quite a positive success actually, kind of across the cohort of patients in terms of improvement in their fluency, speed of reading, errors and comprehension. We predominantly use two methods of treating when we look at stroke. We're either looking at treating around the affected part of the brain, so taking the affected tissue and treating around that, or treating the contralateral part of the brain, which is something we do a lot in tinnitus, and something that we tried in aphasia. Doesn't work for lower limb strokes as much, but there has been some evidence that you can bring the other hemisphere of the brain to almost sort of take over for what the damaged side was doing. So with depression, we've had these systems around knowing how to locate the dorsolateral prefrontal cortex, the F3 marker on an EEG, or a couple of other methods will help us locate where the dorsolateral prefrontal cortex is. But as we started to explore individual patients, particularly looking at things like stroke, we found that if we wanted to do a protocol where we treated at sort of 6 to 8 sites around the damaged tissue, that we couldn't just look at an MRI and then look at a patient in the chair and guess where those spots were, because that's not how it works. And at the same time, we don't have a ready-made calculation for that because every person is individual. Similarly, when we use TMS to treat pain and tinnitus and even things like Parkinson's, the locations of the sites that were being identified in tinnitus often Broca's area 45 or the temporal parietal junction, which is quite a big part of the brain. And so if there was a specific part of that we were looking at treating, we didn't have a good way of determining where that was, which is why we adopted MRI guidance, because that lets us see in real time where we're stimulating with our TMS coil over the person's brain who's sitting in front of us. So then if we decide we can look at a 3D version of the brain, and I'll show you a couple that look like this in a second, we're actually able to sort of say, look, these are the spots we'd like to treat. And then when we have the patient in the chair, we can correlate the patient with the MRI scan, the 3D version of the MRI scan, and actually see some real-time tracking of where the coil is. So you get a little bit of an example of that here, with this being a coil live tracked as we kind of move it around a patient's MRI. So the way we do that is we take an MRI from an individual patient. Often if they've had an MRI before, sadly it won't work with the software. Specifically, we are looking for a T1 weighted 3D volume scan that does include the head and nose, ideally around 1 millimeter by 1 millimeter resolution. So I'm not too sure what is a sort of default MRI in Vietnam, but in Western Australia at least, that would often be dropped out in a quick MRI that might be done post-stroke. That's really just looking maybe T2 flare and sort of a gross structural T1 scan. So we get an individual MRI of the patient, which allows us to, like I said, have this enhanced precision in choosing where we want to treat. And in the real-time tracking, it even helps if we find the patient move or nod off or fall asleep, which does happen a lot with some of our protocols, that a TMS session might go for 20 minutes. They might be lying back nice and comfortable, but as they drift off to sleep, they're drifting away from the coil. And so I actually don't know how much TMS they've had. because they're not sat with the coil in that right spot for that time. And so this can even be set to alarm if the stimulation of the coil moves with it, let's say, 10 mils away from the targeted site. It'll just start beeping. And often it is that the patient's kind of nodded off or rearranged themselves. I will skip over these. Only to say that the evidence for treatment of TMS in depression is the best evidence that TMS has. So a lot of things are growing in terms of efficacy, perhaps, and there are a couple of things that do profess a higher efficacy or success rate over TMS in depression. But TMS in depression is the only one with multiple RCTs, sham, against antidepressants, against other forms of neurostimulation that repeatedly demonstrates a clear benefit. So TMS is very good for depression. I was talking to a neurosurgical colleague of yours earlier who may or may not be here about pain as well. And one of the things that we found very interesting in a lot of our pain patients is, although typically treatment of pain with TMS starts with treating at the corresponding motor cortex, so left hand, treat at the right hand knob, right M1. Although we've had some success with that, we found often a combination of treating at the targeted site corresponding to the pain and treating it like we would depression, so treating at the dorsolateral prefrontal cortex, in a subset of patients delivers quite a big difference. And so it's not news to anybody, but it's that sort of effective layer that can often make pain worse. Some pain conditions are heavily overlapped with psychiatric conditions. And so although patients might not say they have any depression, but they might have chronic pain, sometimes treating at both a site intended for depression and a site intended for pain yields even better results. Skipping through the boring statty bits. This is just more for interest than anything else. This time, put your hand up if you heard about the SAINT protocol coming out of America end of last year. No hands going up. That's cool, because that means I get to tell you something new at least. The SAINT protocol is a protocol designed for the treatment of depression using an incredibly accelerated theta burst protocol. So instead of just doing theta burst once a day, theta burst is a 20-minute treatment sort of condensed into 3. What they've done is they've decided to do 2 lots of that back to back 10 times a day for 5 days. And so effectively they're getting the equivalent of 100 regular treatments, whereas a normal course is around 30 to 35 over 7 weeks. They're getting 100 in 1 week. So that's a rapid departure from the way we've delivered TMS in the past. And I think we'll see this sort of idea follow through into neurology and pain and other fields as well. Because what this is demonstrating is that more TMS does make a difference. And yes, resources have always been a bit of an issue, but I think we've often sort of stopped a little shy from doing enough pulses or enough sessions to really see a difference. And this is particularly true in things like pain and stroke rehabilitation, where you're fighting a bit of an uphill battle. So often more is better. That doesn't mean go out tomorrow and start treating your patients double sessions 10 times a day, but it is that notion that we maybe do need to do more. What was interesting about this study in particular is patients didn't enjoy the TMS at all, and often patients do quite enjoy TMS, but the success rate, the efficacy demonstrated through some of the early results published was good enough to get FDA approval sort of in record time, because it demonstrates, well, we're yet to see sort of clear separation from the old way we've done TMS, but I suspect that's sort of where we're leaning, that this will show sort of better results still. All right. I won't go through how to apply TMS. I mentioned before that we treat at a corresponding motor part when we treat pain. So those that have done TMS before will know that we often look for the hand knob to do what's called a RMT or a threshold test, where we'll try and locate the part of the brain that controls the thumb and index finger and use an EMG to try and determine the dose that we want to apply. When it comes to stroke rehabilitation or pain, sometimes we actually want to identify these targets as locations for the treatment of our TMS. So not just the RMT, but then perhaps the actual treatment. So if somebody had pain in their left arm, I would treat at their right, I don't know which one's left and the right, but I'd treat at their right hand knob as being the corresponding a motor region for that area of pain. With limb strokes, it's more often, well, with lower limb in particular, often they're still trying to use this combination of, do we use the same site or the contralateral site? The benefit of the lower limb is that we tend to get a bit of an overlap in the middle of the brain, and so it is kind of easy to, or difficult, I should say, to determine whether or not the spread of the magnetic field is hitting both hemispheres or one. So again, and so we have we can locate the hand knob easy enough because we can do an RMT and we can measure the EMG on the thumb. And in the past, where we've done pain for legs or even for stroke, we used to put EMGs on people's big toes, calves, so that we knew that we were stimulating over that part of the brain. But what we can remove with neuronavigation is the need to have to do those sort of things, or to pick things where we can't necessarily put an EMG or reliably get a threshold test like the neck or the lower back, which becomes much harder. Because then all of a sudden, I might have done my motor threshold, and so I know this is where the hand knob is. But then if I want to treat sort of lower leg, I can move in along the motor cortex. Now, some people that might go slightly anterior, and some people just straight medial, and other people might even go a little bit posterior. And that's the advantage of having the MRI, to make sure that we are still treating over the motor cortex. So I mentioned this slide earlier. The old way was to sort of use combinations of the NASI and the vertex and the Inian, and there's various calculations or the amount of tape measures I've been through in my early TMS career to try and like locate these sort of spots. EEG markers are probably I guess, are more reliable and slightly easier, but they don't necessarily always correlate to the part of the brain that we want to treat. So just because we're saying F3 is normally sitting over the dorsolateral prefrontal cortex, if we actually look at, what it looks like if we were to study it, we will find that is not always the case. Oh, maybe I don't have that slide here, I apologise. But what we discovered when we looked at, and this is Prof Fitzgerald, not myself, but when we actually looked at the F3, let's say F3 electrode placement for the dorsolateral prefrontal cortex, or a tape measure location for the dorsolateral prefrontal cortex, that there was a huge variability in terms of actually being over the dorsolateral prefrontal cortex. And so often we might be saying this is the spot we want to treat, but we don't know if we're actually treating that spot. So how does the MRI, how's MRI tracking work? It doesn't need much. It needs a working MRI tracking and laptop, which, as you can see right over in the corner here at the moment, I promise we'll be working downstairs in a few minutes, and an MRI. So MRI tends to be the part that historically had been a bit of a barrier. So people, particularly in Australia, MRIs can be quite expensive and there weren't as many MRI machines. But now that we're seeing that being less of an issue, we're seeing bigger, sort of shorter wait times and bigger uptake of people choosing to do MRI-guided TMS because the MRI isn't as much of a hurdle. But that's all you really need. There are sort of two ways. The way that we use with the neuronavigation system that I'm familiar with is around co-registration, which uses a generated magnetic field and a couple of sensors to determine relative in space where the person sitting in the chair would be. The other method that is popular is using infrared, and so that uses instead of having sensors in a magnetic field, it uses infrared to determine again the same locations that we're picking out externally on a patient. Just instead, it'll be using light. So you can see an example of what this might look like in practice down here. The patient will have two sensors that will sit behind their ears. There will be a sensor, the big sensor in the back of the chair, and there's a sensor in the TMS coil. Now, if all of those are sitting in front of the main magnetic field generator, we use our final and fourth sensor to tell the computer where the patient's nose is, identifying these points here, the nose tip and the nasion, and the same with the left and right ear. And then it can do that co-registration in space, where it will be able to determine where, if that is where those bits are relative to the other sensors, and it knows where the other sensors are relative to those markers. And so all of a sudden, the sensor in the coil can now be seen moving in real time over the person's brain. So yeah, as I said, it does create a lot more accurate TMS, even with things like motor thresholds. So we've seen our motor threshold times reduce significantly because there's a lot less trial and error. We're often treating right on the motor cortex first time. And so doing that first RMT setup with TMS becomes much quicker. So in practice, we need, as I mentioned before, a T1 weighted 3D scan. The patient will have some facial markers, and they will be, they'll have to sit still for a moment while those 6 points are determined on their face. I generally do this in a different order, which is why I sort of bumped the picture up on the right-hand side, but we can make these brains ahead of time rather than relying on the software to do it towards at the time of seeing a patient. So I generally, the night before or the week before, will sit down and double check all the brains for the next day and make sure that they have markers in the appropriate places, and any issues with rendering, some of them which can occur, have been ironed out. Yep, and so then the software does its magic, and we'll be able to determine where these sites are and see them in real time. Yeah, so as long as it's a T1 weighted, sorry? 1.5 Tesla is fine. Yeah, 1.5 Tesla is fine. Yep. So as I mentioned, it's really just it's that ability to enhance the way we choose treatment sites, better than this sort of older models. And I did have this slide in here. This is an older study where you sort of replicated this one as well. But you can see that the various ways, so like this one here is good. So I think this is the one from Prof. Fitzgerald, but the blue dots are the way that the DLPFC was determined using various other methods, versus the red dot, which is the actual DLPFC. And so these ones here, the ones that are close, that's not so bad because we know the magnetic field will be big enough to still stimulate that site. But if we look at these blue dots back here and these middle ones over here, we're effectively not treating the dorsolateral prefrontal cortex, even though we did everything right. That's not a user error, that's an error of an old way of determining a location, basically. This is what the software looks like, and even if we can't demonstrate it live, I will show you how it works in a second. It does have a couple of predetermined treatment sites, if you like, but it also allows for the manual input of MNI coordinates or click and drag. So for instance, when we did the aphasia study, the arm in which we were treating around the affected brain. Apparently we'll demonstrate in a second. The way in which because we were determining these sites around an affected part of the brain, we couldn't use a predetermined site. We actually had to sit there and move the markers to the points we wanted to hit. Versus when we wanted to hit the Broca's area 45, it's not preloaded, but there's plenty of old papers that anatomists and neurologists, also neurosurgeons and the like have made around what the NMI coordinates for the BA45 are. And so then we can input that and it will determine where that is for us. We can still double check it against the anatomy, but it gives us a bit of a leg up. So let's have a look at that I'll show you a couple of its features as we go. And happy to take any questions that people think of, and assuming it's all going well, happy for you to come up and have a bit of a play as well. Yeah, and I've got a patient had had every treatment, and when we were able to, with the neurologist, look at her MRI, think about where the symptoms were originating, and give her targeted TMS, similar to the sites we were choosing for the Botox, she had quite a sustained improvement from TMS. She normally comes back about once every 4 to 5 months just to get about a week's top up, but found that that's enough to sustain her migraine free. So now, which not going to be for everybody, but trying to identify these patients and being able to be quite personalised and specific to the symptoms that they're presenting with, or the pathology that they've got, is something we can't do without neuronavigation. Because without neuronavigation, we are just guessing. And so, yes, we'll have patients who have TMS for migraines, no neuronavigation, might not work, but it could be in the complete wrong part of the brain. So whether or not this is sort of more, whether it be muscular related or occipital, like visual field related, so you can be occipital lobe. So different targets for different people. And so that's where it is important to be able to use neuronavigation. Right, so maybe it's working now. We're hopeful. It's one little button that doesn't want to work, and it's working beautiful. So what I'll demonstrate is just effectively how it looks. When we upload an MRI into the software, this version and the recent version came out only a couple of weeks ago, will auto-generate this 3D brain without us having to do it. You do need to know how to do it manually if you're going to use this software a lot, because on occasion, some MRIs won't work with the formula for the automatic process. And if we have time, I'll take you through that. Otherwise, what we end up with is a 3D model of the person with these landmarks that we can use to identify where to start, which is the nose and the ears. But then what we can see is their actual sort of the sulci and the gyrus of their brain, in as much that we can then start to see landmarks, or if we had the MRI next to us on another screen and we were looking for where a stroke would be, we can actually be quite specific in making sure we're treating the right part of the brain. It will try and determine things automatically. So if I ask you to put a marker on the right M1, that's all the dollars in the room are happy that it's the right hand. I reckon it's nailed it. Sometimes it's wrong, and so it's important that you do know your neuroanatomy. What we could say is, in this patient, if we wanted to treat the lower limb, we'd probably come a little bit more back along the motor cortex medially. But see how it's not just a straight line, it comes back a little bit, just because this is then individualized to that patient. Or forgetting that it says right M1, if for some reason we wanted to treat over another region, we can move and drag this point, or we can use the MRI on the side. Now this is not the highest resolution, deepest MRI you've ever seen, but if you're seeing this next to the patient's MRI, this is how I'm able to determine this is an area of stroke, and so we want to treat the periphery of stroke. So this is at the periphery of stroke, and so that's one of our target points. And I'll put another one on, and we'll move that one a little bit higher up. So on the same plane, a little bit higher up. And you can kind of make these points all the way around if you wanted to have a series of points that you want to target. Predominantly, we're using it to determine where that motor cortex is to do our threshold. And the common ones like the dorsolateral prefrontal cortex, it'll pick up pretty quickly because of how often it is used in depression. So what I need is a volunteer to show what it would look like. So the unlucky thing for you there is you're not getting any TMS because it's turned off. So just some navigation. Just navigation, yeah. So the people paying attention in the room will point out that that's not his MRI. That's not you. And so it's not going to be perfect. So if we were doing this for a motor threshold test, it might not work because it's not his MRI. We can actually use a feature in here that uses standardized or top of the bell curve is not going to be perfect because it's not an actual MRI, but it can help for consistency between treatments if the patient, for whatever reason, can't have an MRI. So I mentioned all those little scientific things before, but we've got a big magnetic field generator that we want sitting behind the patient. Now he's a bit tall and this table's a bit short, so if it doesn't work, yeah, that's better, thank you. We then have 4 sensors and they're all the same, which is important because we don't, it's how I guess effectively this works. This is generating a magnetic field forwards and it will determine where all these sensors are. The 2 are going to be static. So the 2 static ones I'm going to put sort of on his ears. This is not my, there's a couple of different ways of doing this. This is just the way it looks coolest. Feels cool. Yeah, very cool. So I just need them to be not moving. Any way I can get them not moving. There are a couple of different versions of this. I've got one that's like a plastic band, and then the sensors go up that way, and so they just sort of sit like a pair of glasses. I find that pretty handy because it's a lot easier to put on and off. During COVID, I had to watch this too many times, so I went with plastic that I could wipe down. But the headbands work fine. So now that those 2 sensors are there, what I'm going to do is tell the computer where the nose and ears are. So somewhere in amongst you, a little point one. So this one right here. Yeah. So 2 sensors behind the ear and a surprise 3rd sensor hidden in here. Exact same sensor. Nothing special to it, it's just the same sensor again. So it sort of initialize it on the computer and then it'll give me prompts down the bottom left where it'll say ASEAN. So we'll put this on an ASEAN and we'll click next. And it'll say nose tip. And then left ear focus. And ear group. And the same on the right. Right, that works. That's a good start. So you can move your head a little bit now. It's just that first we've got to be particular eye. Now I just want to double check that this coil is the one called AP03, yeah? Yeah. You kind of click this button for me. When I ask, you click tolerate. Just want to get this on it. And so then my very professionally attached 4th sensor using what we call sticky tape in psychiatry. So when I calibrate this, I'm going to make sure this sensor's in the magnetic field as well. So often people sort of forget how it works and they'll be here how I calibrate with the sensor and then I wonder why it doesn't work. But you can only see things that are in front of that magnetic field generator. So I put this up here near all the other sensors. It's it'll determine, it'll know how far this is from that, so the shape of the coil, so it'll be able to generate the coil no matter where that sensor is attached. All I do is place it on here on top, and then and then so what we can see is that we actually now have the coil moving in real time over his head. So it's not his head, so it's not going to align beautifully. But then if I wanted to treat that right over the right motor cortex there, actually probably not part of his motor cortex, right? No, that actually looks pretty good, even sitting there.
Hand manipulation.
Yeah. And so if I wanted to treat something like occipital lobe, or if I wanted deep TMS, I can actually then select the marker. This is a superficial structure, but what I can see is I can see like just how close I am. It's like a traffic light system. Green, you see on the top left corner. So green is good, yellow is bad, red is not even anywhere near. So then again, that's the alarm system. Normally you get a little slight peak at yellow and you get a big peak at red. But then it just means that if I want to treat the left arm pain at his right motor cortex, I can just have that there for the entirety of treatment. And if he falls asleep, so you move your head, this is one. Even as he moves his head, because it's all relative, you'll see that it doesn't look like the coil's moving, but that's only because it's holding the head static. But it'll will move because relative to everything else is moving. So that I mean that is it in a nutshell, right? So then the sky's the limit. We can, it doesn't really matter what target we pick. Let's go and hold faith, like hold faithful one. We go left also to a prefrontal cortex, and I can put this. Well, where's the LPFC? You've got different sized head than this person, but it's there-ish. I think it's probably, that's not where his DLP is. I think it's probably too anterior. But again, this is not his MRI. But you can see the I guess the benefit of being able to, in real time, make sure that we are treating a spot that we want to treat. Yeah, that's it in a nutshell. It's pretty good. It is pretty easy when it works. We have, I have 11 TMS machines at 10 sites, so 12 TMS machines at 10 sites. Only 11 with Neuronavigation, only because I have a cohort of patients that can't have MRIs. Some veterans with shrapnel, people with very severe claustrophobia. And so we run one machine that we don't keep it full without using Neuronavigation. It's mostly for depression and PTSD. Anyone for stroke, pain, migraine, and more anyone for depression as well, we use Neuronavigation so that we know that we're treating where we want to treat. I'll show you briefly what it looks like as we sort of load up a new brain. So if we when we say walk into the clinic, or we do this the night before, we've got the DICOM folder from the radiologist, which is the raw MRI data. Let's see what it looks like. So what we have to do, unfortunately, this part isn't automated. We do need to make sure we pick the right scans. These are all the scans within that. So we want the T1 3D weighted scan. So what it will try and do in the first instance is it'll try and import it and make that 3D brain all on its own. And like I said, sometimes it doesn't work. If it doesn't work, all we have to do is tell it what is grey matter and what is white matter, and then it can figure it out. So sometimes the automatic segmentation isn't able to determine that grey and white matter, just because of maybe it's a slightly lower resolution MRI, maybe the patient is moving a little bit, maybe we've tried to use an MRI that it isn't actually a 3D volume one. They can still work, but we'd probably have to sit there and spend a bit of time telling it this is grey matter, this is white matter, this is grey matter, this is white matter, and then we'll just sort of like ping up once it's done. One of the things that I can show a brief video of, which is just around, particularly useful in neurology, is I guess mapping, multiple motor mapping. So it's mapping the activity or deficit of a part of the brain with a corresponding muscle group. So if we had the arm or the hand, for instance, we can map around the hand knob and actually on this software, assuming we had our EMG here, you'll be able to see like red dots where it's the hottest and out to orange and yellow. So while you're here treating all these spots around the hand knob, you can actually then see on this 3D brain, like where is it hitting up the hottest for the hand. And where it works really interesting is when you've got a deficit, so they can't move their hand, it'll help you locate where that is or if it's been damaged, which it is useful then for determining treatment sites or for the origin of the paralysis or the inability to move. So that one hasn't generated, so we have to load it up and do it the manual way, which I won't do, so I want to show you this video instead. But if we were to, all we would do is, as I was saying, we would then sort of set a couple of grey matter markers, and we just make sure that they're in the grey matter on the, they are, then they come to the white matter, which normally gets wrong. Look at that. You see how this scan, see how the colour difference between the grey and the white matter is amazing on this scan. So because that was the right type of scan, it's not want to sit there just in case. You can come back in a second if you want, or you just want to stay there comfy. I'll quickly show you a brief video around the motor mapping, and if anyone wants to come and have a little bit of hands-on with the neuronavigation, I think that would be a good idea as well. So I'll just very briefly play this.
Welcome to this instructional video on how to map the motor area using the Neuronavigator navigated MEP. We will start by preparing our patient by placing the EMG electrodes over the muscle of interest. In this case, we are mapping the first dorsal interosseous muscle of the right hand. We attach the ground electrode to the wrist. Next, we place the recording electrode in black over the muscle belly and the reference electrode in red over the tendon. Now that the EMG electrodes have been placed, we can start the NeuroMap software. This software allows us to record the EMG traces. Go to Magnetic Stimulation. In case you have not yet set up Neuronavigation, you can find instructions on how to do this in our video on how to perform Neuronavigation. Now we can start navigating. Whenever we deliver a TMS pulse, a sphere will appear on the brain surface. The position of the sphere indicates where the TMS pulse was delivered. The color represents the amplitude of the evoked response in the muscle. We can stimulate different targets in the brain to generate a delineation of the area in which responses are evoked in the muscle. For each stimulation target, you can find the machine output, the amplitude and latency of the evoked response, and the X, Y, and Z coordinates of the stimulation target in the table in the MEP tab. You can also view the waveform in the panel above. To explain additional features of the software, we will load a different dataset. In this dataset, a grid of points has been stimulated. You can adjust the color scaling of the spheres by changing the minimum and maximum amplitude of the evoked response. You can also select a different color map from the drop-down menu. You can adjust the visualization of the stimulation targets by changing the spheres to flags. The advantage of using flags is that they point in the direction of the TMS-induced current. If you are using multi-channel EMG, you can visualize different channels by selecting the channel number in the drop-down menu. Finally, you can filter the data based on features of the data. For example, you can visualize all the responses with an amplitude of more than 1 millivolt.
So that's pretty much that. So particularly the flag one is really interesting when we do research because historically when we've treated depression, we've had this 45 degrees because the way the dorsolateral prefrontal cortex moves, we want to be perpendicular to it. And the same is generally true when we're treating pain. We want to be perpendicular to the gyrus, which is predominantly anterior posterior. So instead of being on a 45 like it is for depression, the coil would normally be, so sometimes we would try to say 45 for depression. For anything with pain, we want to go very anterior posterior to make sure that it's perpendicular to the gyrus. But you saw that individuals' brains look differently, and so sometimes that little direction might help. So when we do the research in these kind of conditions and we use the flags, we can actually then not only change the location but the angle and see if the angulation actually makes a difference in terms of evoked potential. So anyone that's done a bunch of TMS before will know that sometimes you can be in the right spot. It can be these weird little tilts and changes that is the difference between a thumb response and no thumb response. And so that is trying to really just provide some meaning to that in terms of being able to visualize what that means. It is really powerful with a multi-channel EMG because you can then do multiple muscle groups in the hand all at once without having to tap between them. So you can map that part of the brain, and you can visualize those different muscle groups as opposed to having to do it one muscle group at a time, which obviously does take a fair bit of utility for this is mostly in that stroke rehabilitation or identifying deficit or helping us find the healthy preserved tissue that is still causing an evoked response and therefore might become the target of treatment. So would anyone like to come and have any questions, or is there anyone to come and sort of touch and play and help him feel happier and his migraines?
Any comments? The lady, she have any issue?
So bring my bag of goodies. I have a cap. So I still use caps as a backup. So technology fails all the time, and as good as this is, it's not as good as the technology, the software that neurosurgeons get, because they're not allowed to be out by a couple of centimeters. We are allowed to be out by a couple of let's go.
This lady, she's very intelligent regarding to Vietnamese business, and during the past of 10, 15 years before, you have to borrow the navigation to perform the deep brain stimulation. And she's very flexible, flex the time of the younger doctor.
If our patients are going to like a more remote site where I won't be able to get there and necessarily help them, I'll often put the cap on. So it's just a swimming cap. I'm not going to actually do it. Just a swimming cap that goes on. And then when I've determined the treatment site using Neuronavigation, which I normally do up in my sort of our main thing where most of our staff and machines are, what I can do is then I can just draw around it, and then they can take their cap with them to the clinic. And most of the time it's going to do Neuronav, but that's like a backup. So I've got people that are in the country, they're 2 hours away from me, the Neuronav goes down, they can still have treatment today. The cap goes on, quill goes on, away you go. Because I drill on the cap using the Neuronavigator, so the cap is right. We used to do the cap all the time as well.
Exactly, the cap.
If I'm doing it with the Neuronav in my office, the cap will then be right. So it's still backup. And if you, I have Neuronavigation everywhere, but I could do it that I only have Neuronavigation wherever the mapping is set up. But all my other machines almost don't need Neuronav if I use the cap. But so there are ways. It generally isn't. I haven't had too much in the way of problems. This is being used for the first time today, and so we've actually gone through the full setup, which is a little bit of a headache because I got in it. I left hoping at 5 o'clock this morning, so maybe we're a little rushed. But once it gets going, it tends to be okay. This particular piece of software, the team that services it are in the Netherlands, and I've found them very good in terms of replying to messages from me, usually from about now onwards because they're asleep for the first half of our day, where I'm on the same time zone as you. So that's saved me a few times in a bit of a pickle. The biggest issue is just training staff on using it, training all my nursing staff and doctors on using it, which is that's sort of a problem once you get to a volume, right? So like we had a training day recently, and it was easy because most of my staff are teaching now, not so much me. And so that's probably another factor. If you're the only one that knows how to use it, then there's sort of no help if you're not there. Then it can't be used. But we had our nurses deliver the treatments after the patients have been set up, and they probably know how to use this better than I do, I would say, because they're using it a lot more than I am, because every minute of every day.
So thank you for your presentation. Very interesting for our audience. And the last gift is the certificate appreciation. For us, it's always that the gift, but nothing. And excuse me, I remind all of my colleagues that on the Monday next week in the afternoon from 2 o'clock p.m. to about 4 o'clock p.m. Monday next week, we have a workshop of Professor Kiel in the medical center of Vạn Hạnh. And but during this time, maybe I suggest he talk a little bit about the option for treatment of depression and anxiety. The option, choose the optimal manipulation for anxiety and depressive patient. Okay, easy. He said easy. So let's move on. Thank you so much.